Uh, can we start the session? Do we have first presenter here? Dr. Gautam Jain. Yes, please.
Good morning. Can we start?
Yes, please start.
Good morning. My topic is effects of Nd:YAG laser capsulotomy on intraocular pressure and anterior chamber depth. As we all know, the lens is a semi-solid avascular biconvex structure and it contains lens epithelial cells which lies in anterior, pre-equatorial and equatorial regions, and the cataract can be age related or caused by UV exposure, smoking, poor diet, and it leads to lens opacification. And a posterior capsule opacification is a common condition after cataract surgery which caused by lens epithelial cells which grows on the posterior capsule, which impairs the post-op vision for the patient, and treatment for that is Nd:YAG laser capsulotomy, which creates an opening in the posterior capsule. And the few risks which associated with Nd:YAG laser is IOL displacement and pitting, and few central macular edema and retinal tears. As a prevention of posterior capsule opacification, capsule polishing and sharp edge IOLs can be used, and Nd:YAG laser often needed despite preventive methods. Objective of my study is to investigate the effect of Nd:YAG laser capsulotomy on intraocular pressure and anterior chamber depth to assess the clinical relevance of these changes and their implications for the postoperative care. It is a prospective study which includes 123 patients who underwent cataract surgery and presented to us with the posterior capsule opacification at our center. We divided the patients in two groups according to the energy exposure. Group 1 includes energy less than 30 millijoules and group 2 includes energy more than 30 millijoule. We included all the patients with the PCO which diagnosed via slit lamp biomicroscopy and excluded the patient with the ocular comorbidities, active infections and cataract due to specific conditions like pseudo-exfoliation and trauma. We measure the IOP using Goldsman applanation tonometer and anterior chamber depth via ultrasound biometry. As a pre-treatment, we dilated the patient with eye drop tropicamide and phenylephrine, and if needed, we use topical anesthetic also. As a post-treatment, we used eye drop moxifloxacin and eye drop dexamethasone for 2 weeks, and we monitored the intraocular pressure and anterior chamber depth at 1 hour, 2 weeks, and 1 month. As a result of my study, I have noticed that there is a significant increase in IOP post-laser in both the groups, and group 1 includes a pre-laser mean IOP is 15.48, which peaks at 1 hour post-laser and which comes to baseline at 1 month. Similarly in group 2, but there is a group 2 showed a great peak increase as compared to group 1. And in terms of anterior chamber depth, the group there is a slight and significant increase in anterior chamber depth, which also comes to baseline, around baseline at 1 month post laser, as shown here. Also the changes in IOP and changes in anterior chamber depth. As the previous studies also includes the changes in intraocular pressure and anterior chamber depth by Nd:YAG laser capsulotomy. They mentioned that there has increase in intraocular pressure, but there is no change in anterior chamber depth. But in my study, I have noticed that there is transient increase in intraocular pressure immediately post procedure, but IOP returned to pre-laser level by 1 month, and anterior chamber depth there is a slight increase, especially in the first hours post laser, and it gradual decrease by 1 month follow-up. Findings about the safety and efficacy of Nd:YAG laser for managing PCO consistent with the existing literature. And as a take-home message, Nd:YAG laser capsulotomy is a safe and effective procedure for managing PCO. It leads to improved visual acuity, transient IOP elevation, and slight changes in anterior chamber depth. There is no significant complication, reaffirming the procedure's efficacy and safety. Regular post-procedural monitoring of intraocular and pressure and anterior chamber depth is essential for early detection of any complication. Thank you.
Doctor, you have taken the IOP readings 1 hour, then 2 weeks.
Yes, sir.
Why this kind of schedule you have chosen?
Sir, because there is many reference studies includes that IOP should be measured after 2 weeks after NDA laser capsulotomy.
No, what about the initial rise after the YAG? What
Yes,
about the period which is the where the IOP rises maximally?
Sir, at 1 to 2 weeks, sir. But I have taken all the data at 2 weeks for a reference point for all follow-ups for all the patients.
So you will wait for 2 weeks to record the IOP after YAG?
Yes, sir.
For
First,
a
I have
clinician
taken.
who does YAG today, the
Yes, sir.
IOP should be measured after 2 weeks?
Yes, sir. At immediate first 1 hour post laser and then after 2 weeks.
Okay, fine. Next
Thank
patient. Can we start the timer please? Dr. Sheetal, is she here? You can come and present. Two? Okay, fine. Okay, fine, start.
Should I start, sir?
Timer, please.
Good morning, one and all. I am Dr. Sheetal, and today my topic is there is a 2 years case series on rhinoorbital cerebral mucormycosis at tertiary cancer center. So there is increase in general population of fungal infection, most because of the diabetes stresses like uncontrolled and fungal organism which are common cells in human body. It will be the life-threatening infection mostly in immunocompromised persons due to lack of neutrophilic and phagocytic response. So mucormycosis is highly aggressive and invasive infection caused by group of filamentous accepted fungi. The most common pathogen in this group are Rhizopus, Rhizomucor, mucor and Lichethymia. So mucormycosis basically it is divided into on the basis of anatomical side on 6 types, like one will be the rhinoorbital cerebral mucormycosis, which I am going to discuss. Then second will be the pulmonary, third will be the cutaneous, then fourth will be gastrointestinal, disseminated and of uncommon site. Early diagnosis it will be the difficult because of the patient mount to host response or because of inconspicuous early symptoms and sign. So the purpose of my study is that to study the various clinical presentation of this mucormycosis patient presenting to ENT and ophthalm departments, and to find out the species distribution and treatment outcomes in patient of this group. So this study was carried out from June 2018 to February 20 in both ENT and ophthalmology department. So, and after obtaining clearance from ethical committee, and patient with clinical suspicions of mucormycosis were included. So in diagnostic we did nasal endoscopy and radiological examination, either CT or MRI of nose and PNS, orbit and cranium for all such patients. Then also tissue specimen was taken during endoscopic examination and sent for KOH mount. Then a patient with clinical suspicions and without laboratory confirmation were later excluded from study. Patient also underwent surgical treatment and antifungal administration at the like after admission. Then the patient with disease progression who had died during the hospital treatment, they are considered as poor outcome, and who were patient was stable throughout the treatment, it is like labeled as favorable or good outcome. So firstly we took 18 patients, but after that 2 patients were excluded because one came as a sinonasal malignancy and other was diagnosed with having aspergillus. So total 16 patients we have analyzed. So depending on age, like 54 to 66 and 44 to 53 age group, they are most common, and the young age, like it is a little bit less on side. On females, they are on more side as compared to males. Then obviously uncontrolled diabetes mellitus, they are having most vulnerable outcome. Then presenting symptoms like patient were most common were coming with swelling of the cheek and thick blunt stain discharge, like in 9 patients. Then rest of the patient, they are coming associated symptoms like few are having visual disturbance, protrusion of eye, then pain over cheek and altered sensorium. Also nasal involvement like more common, ischiocytes, then palatal and ophthalmoplegia were seen in 5 patients. Then we can see like in more of ENT side there is sinus involvement also. On a lot like maxillary and ethmoidal sinus are most commonly involved. Then coming to species, like we got Rhizopus species is mostly involved. Then what we give treatment, so all patients underwent repeated surgical debridement under endoscopic guidance, and along with that we have also started before like treatment, before result only amphotericin B after taking opinion from the nephrologist. Then orbital exentation was done in 7 patients and rhinectomy in 1 patient. Like I previously said, favorable outcome was seen only in 4 patients and unfavorable in 12 cases. And unfavorable was because of associated underlying symptoms, like some are having myocardial infarction, septicemia, and progression also. So what is our discussion, like diabetic mellitus was the single most important risk factor. Then radiological investigation also helps in assessing the extension of disease and helps in the management of the disease. Then also Rhizopus was the most common species what we got, and majority of the patients were not able to afford the costly amphotericin B formulation also. So that also went unfavorable outcome. So what is take home message or conclusion? It is like although mucormycosis is treatable condition, patient should be aware and it should be come in like early detected set or early diagnosis, so that we can give proper management, and prompt suspicion and diagnosis is also needed. And empirical supported treatment can be initiated when it is the suspicion of the condition is present, and we don't have to wait till the reports come. Thank you.
So you have done the study before COVID.
Sorry, sir?
The study was done before COVID.
Post-COVID, sir. All those are post-COVID. 22, 23, like just after say first wave.
No, you said 18 to 20.
Sorry, that's 20 post-COVID, sir. Like we started,
Pre-COVID.
but
Pre-COVID, no?
Pre-COVID.
Not after.
means not, but in between also we took that cases.
So because COVID is also a risk factor for
Yes, sir.
ROCM. So what do you want to messages for in cases of COVID, the presentation is little different. How it is different in COVID than the normal?
So basically they are having few patients are coming repeatedly, like they are giving proper history of COVID and newly detected mucormycosis, but on COVID history, like they have undergone intubation or such patients without any previous history, they are also getting like mucormycosis. It's like few cases we are getting now also. So we have to think about, we have to take proper history about COVID also, like any prior history of COVID or anything that.
So is there any different presentation is different in COVID related cases or the normal?
No, sir, that much difference we didn't get. But post-COVID, we are getting more mucormycosis as compared to like pre-COVID.
Yes, actually in COVID, a lot of patients are presenting to the ophthalmologist first rather than to the ENT, because they are having mainly orbital pain or periorbital swelling. That is the first presentation, many COVID related cases. Okay, fine.
Thanks.
Yeah. So, next presenter, please. Dr. Malik. So, please.
Good morning. I am Dr. Praveen Malik, Academic Head, ADK Eye Hospital, Khekada, Bagpat District. Cataract remains the leading cause of visual impairment worldwide, and cataract surgery is one of the most commonly performed ophthalmic surgical procedures. Despite of all the technological advancements, poor surgical outcomes are associated with cataract surgeries in rural settings globally in developing countries, and its incidence varies from 11.4% to 44%. Risk factors identified in some studies include rural residence, increasing age, female gender, lack of education, and free surgeries. Earlier, camp-based surgeries were of concern, but now transition from camp-based surgeries to hospital-based surgeries have resulted in better outcomes. WHO categorizes the visibility outcome following cataract surgery as good if the visual acuity is 6/18 or better 6 weeks after surgery post-operatively, borderline if the visual acuity falls in between 624 and 660, and poor if visual acuity is less than 6/60 6 weeks after surgery post-operatively. Being the most commonly performed surgical procedure that impacts blindness prevention strategies, monitoring cataract outcomes is extremely important. WHO recommendations are that more than 85% of operated eyes should achieve good visual outcome and less than 5% should fall in the category of poor visual outcome. They have shown and established at LV Prasad Eye Institute in one of their publications outcomes of cataract surgery in urban and rural population in the southern India state of Andhra Pradesh, Rapid Assessment of Visual Impairment Project, that outcomes of cataract surgery in rural areas of India are poorer than in urban areas. On the other hand, some studies have shown that outcomes in rural areas can be comparable to those in urban areas. With this in mind, and to assess and reflect on visual outcomes in our rural setup of ADK Jain Eye Hospital at village Khekda, Bagpat district, Uttar Pradesh, we designed a retrospective descriptive study, which included 3,165 consecutive patients who underwent cataract surgery, SICS, and phacoemulsification with intraocular lens implant from 1st January 2024 to 30th June 2024. Type of IOL, whether posterior was implanted or anterior lens was implanted, absence of IOL, if any, and all surgical complications were noted. Best corrected visual acuity after 4 weeks of surgery was also noted. Amongst all complications, posterior capsular rent was noted in 2.59% and post-operative best corrected visual acuity of 6/18 or better was achieved in 82.02% of patients, while preoperative visual acuity was less than 6/60 in 77.91%, which is a big number. So it can be seen that good outcomes post-cataract surgery were achieved at our ADK Eye Hospital Khekda at par with WHO recommendations, and we attribute it to our scientific state-of-the-art operation theatres and meticulous planning of all surgeries. Thus, it can be safely concluded that cataract surgery outcomes in rural areas can be compared to those in urban areas, according to our study. Thank you.
Sir, you are doing good work in Khekda. That is nice to know. One thing I wanted to know, are there any difference, have you noticed any difference in the expectations of the patients in the urban area versus the rural area?
In fact, I've been working all through my life in urban area only.
Yes.
I was head of the department of RML Hospital, and now I'm working as academic head in ADK Jain in rural area.
So did you?
Hardly any differences. Basically, depends on your OT setup, your equipment, and I mean the patients are in fact more easily satisfied in rural areas.
Yes, that is what I was coming to, probably your experience.
They are more
Because
whimsical in cities than urban areas.
okay, fine. Thank you, sir.
Thank you.
Dr. Mugdha? Yes.
So, good morning everyone. Myself Dr. Mugdha Jain from ADK Jain Eye Hospital Khekda. I shall be talking on magnitude of cataract in India, a review on it. So let's address the problem first. Cataracts are the leading cause of curable blindness worldwide, we know all that. According to the WHO, as of 2021, there are an estimated 2.2 billion individuals living with near or distant visual impairment. Approximately 1 billion people of them suffer from moderate or severe distance visual impairment, with almost 94 million diagnosed with cataracts. Cataracts are responsible for 45% of global blindness in 2020. But India was the first country to start a blindness control program in the world with the National Program for Control of Blindness and Visual Impairment in 1976. Program aimed to reduce blindness and visual impairment through various interventions, including medical treatments, surgeries, and awareness campaigns. According to National Blindness and Visual Impairment, NPCB-NVI survey 2015 to 2019, cataract contributes to 66.2% of blindness and 71.2% of visual impairment in the population above 50 years in India. But the demographic transition and improved healthcare access have led to a growing number of older adults in India. The older adult population is growing about 3 times higher than the overall population in India and is likely to be 20% of the population share by year 2050. And we know that the impact of cataract extends beyond visual impairment as it can significantly affect individuals' overall well-being, independence, and quality of life, imposing a substantial economic burden on individuals and society. WHO recently adopted the resolution on integrated people-centered eye care, IPEC, including preventable vision impairment and blindness, and within it proposed the development of feasible global targets for 2030. And where are we? So according to National Blind Visual Impairment Survey 2019, coverage for cataract surgery among blind individuals and visually impaired people was 93.2% and 74% in India respectively. But the good news is, under National Program for Control of Blindness and Visual Impairment, a mission mode cataract surgery campaign known as Netra Jyoti Abhiyan was launched to be between 2022 to 25 to clear backlog of eligible cataract cases by allotting yearly targets to each state and union territory. For the financial year 22 to 23, a target of 75 lakhs cataract surgery was kept, against which 83 lakhs cataract surgery were done. This drive is a major step taken to reduce the prevalence of avoidable blindness to 0.25% by 25. Similarly, the targets for 23 to 24 and 24 to 25 have been proposed. But future targets are WHO recommends a rise of 30% of effective cataract surgical coverage by 2030, which will make a higher target of 66.67% from the existing ECHC of 36.7% in India. To achieve that, we need to focus on activities that can enhance the quality of cataract surgical care and monitor the standards set by WHO. Thank you.
I have one question for you.
Yes, sir.
Am I audible? Okay, so you know the cataract itself is, we know the pathophysiology of the cataract, how it causes, and like we know everything about the treatment available. So why in India it's so difficult to eliminate the cataract? What do you think? What is the best answer?
Sir, the emerging causes are, first is we know that out of the many causes of cataract in India, the main is we have the older population which is rising. The first is that. Secondly, our climate, the tropical climate in which we live. Thirdly, the access to the surgical care and the amenities and the facilities we don't have. Fourthly, the economic facilities, the economic patients do not have so much of money to reach to the services. Because we see in our center also, there are so many people who are not willing to spend even a penny because they don't have it. So we are doing almost every day, we are doing camp surgeries, and so many of them. And we are so delighted to offer them surgical care. And sir already showed that we are giving good results also. So the reason is that whenever we ask them, suppose any investigation is required, apart from cataracts, then they are not willing to do it because actually they don't have money. So the access to and there are not many places, not many hospitals who are offering free surgical care. So I think these are the reasons why.
So you mean to say that the aging population is one factor and the lack of infrastructures in the remote area. But you see, that now that surgical skills, so there's an issue in terms of surgical skills because in the latest National Blindness Survey, that post-operative, that cataract surgical outcome, we aim to have someone, get operated to have a vision 6/6. But the post-surgical complications is Dr. Praveen.
Yes.
So it's second most common now. It's, not a second, third most common cause of visual impairment.
Yes, sir.
So
According to the survey of 2015 to 19.
So as he said, a surgical expectation, the patient expect to have a best vision acuity 6/6 after surgery. So the trust and belief also now, the issue. Okay.
Yes.
Anyway, thank you.
Thank you, sir.
Can we have Dr. Sarnitha?
Good morning, everyone. My presentation is on ocular profile among bus drivers and conductors. The main aim of this study is to study the incidence of ocular manifestations among bus drivers and conductors in Gadag city. Public transport is the vital force of civic headquarters, connecting people to their destinations. Visual health of bus drivers plays a crucial role, contributing about 90% of the perceptual and cognitive inputs essential for safe driving. Bus drivers, by virtue of their profession, face unique and relentless visual challenges, including sustained attention and quick responses to dynamic surroundings. So, regular eye test and awareness of visual impairment can significantly enhance the safety and operational efficiency. It is a prospective study which was carried out in Gadag city among 100 bus drivers and conductors. Basic personal details and history regarding ophthalmic complaints were taken. The history of diabetes, hypertensive and any other comorbidities was taken. Visual acuity using Snellen chart, refraction, intraocular pressure, color vision, slit lamp, biomicroscopic examination and dilated fundus examination was done. It was found out that among 100 bus drivers and conductors, 18 were diabetic and 11 were hypertensive. Among all the ocular manifestations, refractive error was more common. Among them, presbyopic turned out to be the highest among the bus drivers and conductors. This study is an effort driven by the dual target of improving the benefit of these professionals and confirming the security of those who depend on public transport. With a focus on unique visual demands faced by these professionals, the study delves into ocular challenges and vision-related symptoms experienced during their work. This research combines the quantitative assessment of visual acuity, refractive errors, and vision-related symptoms with qualitative insights from the bus drivers. Similar studies have shown that the most common ocular morbidity was refractive error. In our study, the ocular manifestations seen were cataract 28%, pterygium 22.6%, presbyopic were 46.6%, and allergic eye disease was seen in 5.3%. Picharis et al. Reported that almost 20% of the two-wheeler accidents were caused due to collision with the buses. Vision function threatening systemic diseases were present in 25% of the drivers, out of which diabetes mellitus were 18.7%. In our study, it was 0.05%. I conclude that several bus drivers suffer from vision threatening systemic and ocular disease. Some of them require surgical intervention to retain fitness. Regular eye examination and vision correction not only benefits the bus drivers and conductors, even helps in safe and efficient public transport. The importance of regular treatment should be frequently emphasized, as poor compliance has been often reported in patients with long working hours. The drivers should be educated about the systemic diseases which can affect their driving skills, and they must be encouraged to seek medical help at an early stage. These are the references. Thank you.
These bus drivers were all government employees?
Sir?
These bus drivers and conductors were all government employees?
Illa, sir. Or like both government employees and private employees, sir.
Both?
Both, sir.
So, did you give some recommendation to the authority for their checkups?
Yes, sir. Most of them were of private, sir. Government employees, we got authority from them.
You see, because you have mentioned that a lot of, and one thing, you have combined the data, the bus drivers and conductors, because the role is very different. The role of driver is very different than the conductor. So if you mix up the data, the inferences we get, they are not exactly applicable to both the professions in totality.
Yes,
You get my point?
Yeah.
So ideally should have been the
Bus
problems
drivers.
of drivers and problems in conductors, because they are two different, and drivers obviously have very crucial role to play in the public transport.
Yes, sir.
So
one important driver your study, I would say, it is very important. Do you know what is the government recommendation in terms of the best character vision equity should have, one driver should have, like, the government has to, government needs to issue the driving license. So do you have any idea on that?
yes.
Huh? कितना vision होना चाहिए driver to issue a license, and in terms of field of vision, in terms of BCBA. Have you thought about that?
Yes.
ये ज़रूरी है नहीं है? हाँ? Because driving license is a must. और bus driver है.
So normal visual acuity and this fundus examination are done before giving issuing license, driving license.
So you should check it out that also. Okay, what is
Yes.
the recommendation from the government side? It is there. Okay, thank you.
Yes, very important. Dr. Tiwari, Dr. Sneha, is she here? Next presenter. Then Dr. Vanaja. Yes. Sure, you can.
Role of B-scan ultrasound in preoperative evaluation of posterior segment in dense cataracts. Blindness in South Asia due to cataract is 51%, and the incidence of cataract in India is 0.4 to 0.5%. In patient with dense cataracts, fundus view may be obscured, and B-scan ultrasonography helps in posterior segment evaluation and surgical planning. B-scan is a non-invasive, efficient, reliable, and inexpensive diagnostic technique for evaluation of ocular pathology. Both A-scans and B-scan techniques are important for the diagnosis of posterior segment lesion and give vital information regarding the status of vitreous, retina, choroid, and sclera. There are few studies done to evaluate posterior segment using B-scan ultrasonography in case of dense cataracts. Material and method: this study included 1,005 patients with dense cataract where fundus was not visible. Patient underwent anterior segment evaluation by slit lamp and posterior segment using B-scan. Postoperative fundus evaluated to correlate with preoperative findings. Chi-square test assessed sensitivity and specificity of findings. Results: total 1,005 patients are analyzed, in that males are 455, females are 550 with diabetes 65, hypertension 147. In that hypermatures are 249, intumescents are 21, mature cataracts are 730 with Morgagnian is 5. Comparison between the pre-op B-scan findings and post-operative fundus examination. In 1,005 patients, there is normal 944 with astral hyalosis 21, fine vitreous opacity is 5, vitreous degeneration 29, vitreous hemorrhage 6, posterior vitreous detachment 38, choroidal coloboma 2, posterior staphylomas 2, tractional retinal detachment 1 with optic disc notch 33. Here the sum of the funduses showing with astral hyalosis, optic disc cupping, choroidal coloboma, tractional retinal detachment, vitreous hemorrhage with retinal detachment. Status of vitreous: the sensitivity of the vitreous is 99.5%, specificity is 100%, positive predictive value 100%, negative predictive value 91.8% with diagnostic accuracy 99.5%. Status of VR interface: sensitivity is 100%, specificity is 99.48%, positive predictive value 86.8%, negative predictive value 100% with diagnostic accuracy 99.5%. Sensitivity and specificity of RCS complex is 100%, positive and negative predictive values are 100% with diagnostic accuracy 100%. Sensitivity of optic disc is 91.8%, specificity is 100%, positive predictive value 100%, negative predictive value 99.69% with diagnostic accuracy 99.7%. Overall results of chi-square test for sensitivity is 95.40%, specificity is 99.23%, positive predictive value 92.2%, negative predictive value 99.56% with diagnostic accuracy 98.90%. Dense cataracts constitute an important cause of blindness in developing countries including India, and many cases have dense cataract that preclude the visualization of fundus prior to surgery. Under such circumstances, B-scan ultrasonography can provide valuable information regarding structural abnormalities of posterior segment. It helps the surgeon to provide an appropriate visual prognosis to the patient. Conclusion: this study shows usefulness of B-scan as a diagnostic tool to visualize the posterior segment lesion and can be performed routinely preoperatively. Thank you, sir.
So your patients, this was conducted in 1005 patients.
Yes, sir.
So any change in the course of management was taken up when you found asteroid hyalosis or some other pathology?
So there is a decreased, with the normal patient, there is the visual outcome is less than the normal patient, sir.
So you were explaining this to the patients?
Yes, sir.
But what about the macular diseases? See, mainly we have macular problems which cannot be detected by B scan.
Yes, sir.
So what
But
do you do
some
in
of
such
the
case?
diseases, it is.
I just missed the research question. What was the research question for your study? Because you have done some statistical analysis also, sensitivity, specificity, and the PP. The research question, what was the research question?
It was a research question. You have mentioned all those sensitivities and
we have
specificities.
done a
So,
lot of
so why
analysis.
you have done that? What was the question for that? You were assessing the B scan specificity and the sensitivity, or
Yes, sir.
Yeah, so the question is, before you start your study, so the research question in your mind, so you must be having research questions. So why you want to do this study? So
Because
did
the
you decide
visual
on that?
prognosis to the explain to the patient, it is depending upon the B-scan findings, sir.
okay, fine. Thank you.
Thank you, sir.
Dr. Sheetal Sabur, next presenter, please.
A very good morning to everybody. So, my paper is regarding an insightful look into incident reporting in ophthalmology. So, a patient safety incident is any unintended or unexpected incident that could have or did lead to harm of one or more patients receiving health care. An inquiry is necessary to prevent recurrence. Targeted safety improvements help improve quality care. Reporting eye health related incidents is still in its nascent stages in India. So, the hospital is accredited and staff and students are trained to report incidents. The details of the incident are described in a form which also include corrective and preventive action, and this is discussed in detail in the Safety Committee for Implementation. Our study aimed to describe and characterize safety incidents related to eye health in a teaching hospital in Karnataka. This is just a sample of the incident report, and it's clearly mentioned that incident reporting is not meant for blaming anybody or taking punitive action. Here the details of the incident, when it occurred, the description, the circumstance of it, and also the corrective and preventive action is described. So our study intended to study incidents that were reported in the Department of Ophthalmology between May 2022 to July 2024, almost a 2-year period. And this was in a teaching hospital in coastal Karnataka. And this was analyzed from the incident records. Only 10 incidents were reported. Actually, there were 15 that had occurred. And also, the description is there of the root cause analysis and the corrective actions. These were the common categories: medication errors, communication errors, equipment failures. And 7 incidents resulted in moderate harm, but no permanent morbidity. So in medication error category, in one of the cases, there was a discrepancy of wrong dose and duration in the doctor's orders and the drug chart, and it was a near miss. In another, there was a prolonged duration of the drug that was administered and which resulted in side effects. In a third, the verbal orders were not followed correctly and the patient received wrong medication. In communication errors, there was one particular case which resulted in hyperkalemia. This was an ICU patient, and primarily there was no communication between 2 departments that were treating the patient. And there was one case in which the patient did not inform the bystander regarding his vertigo and resulted in a fall. Then there were two equipment failures where phaco machines and the vitrectomy machine failed intraoperatively, and administrative error where patient had a fall due to wet bathroom floor and a staff member twisted an ankle due to slippery floor. So to conclude, incidents were underreported and mostly resulted in moderate harm. No non-clinical incidents were more than clinical incidents, and clinical incident reports were mainly in the form of medication errors, communication errors, and equipment failures. Improved reporting system and staff training mechanism reduce these errors and improve patient safety and outcome. Basically, we need more awareness regarding coming up with mistakes so that system flaws are taken care of and it improves patient safety. Thank you.
A very nice study, and it can be eye-opener for any institution. But the problem is, I mean, your hospital is accredited, but what about those hospitals? What message do you give to those hospitals who do not have accreditation?
Well, I don't think we really need accreditation system, but we have forums like this, wherein we promote, good practices of owning up your mistakes, not to be blamed, not to have individuals blamed, but the whole thing is to improve flaws in the system. I think attitude change will come slowly, but these are platforms where we can increase awareness, if not for accreditations that happen for each hospital or institution.
And you mentioned about staff training, but training is okay, but what about the implementation? That is the main issue.
Yeah, it's not very easy. Even if you're accredited, it's not easy. I think you have to persist. You must not give up. And it should begin from the top, wherein, the seniors start admitting that, okay, this went wrong. And you never punish somebody who owns up a mistake, because it's the system we have to change, not blame the person. That is very hard, but that is what is necessary to bring awareness
But
about.
some form of communication should be there for the person who was involved, or inadvertently that happened.
Then they get, they feel very scared. Nobody will report it.
How will they know that they have committed a
It's
mistake?
like a general thing. You change the system. For example, now a wrong IOL has been put. You don't tell you put the wrong, you didn't check. You devise a mechanism wherein you have a 2-level check. So you put that system in place, and automatically they will get into the system.
So, who's going to supervise this system?
As the head of the department, I'll have to do it, or there is quality department if you are an accredited hospital. It's not very difficult really to put a system in place.
Yes,
Not all that difficult.
Because we have a manpower problem in the government scenario also.
Yeah, no sir, it's very much possible. You need the will, that's all.
Okay.
Yeah.
You have shown that so many errors, starting from the, the medication error, communication error,
Yes.
and so when you come to the medical legal aspect, so that medical negligence, do you think that there is something which related to the medical legal aspects? Because we have shown 5-6 error.
Yes.
So
Sometimes it can be. See, we got lucky that nothing happened. But yes, sometimes there can be. What if the patient with hyperkalemia had an attack or something? I don't know how the medico-legal error part will work in this, because in Ophthal we really don't come across, but I'm not really very sure about this. There is an implication though.
Yeah.
It can happen.
Yeah.
How to go about it, I'm not very sure.
See, because you have so many errors, so in one
Yes.
error there must be some medical legal aspect, because someone who is quite literate, because of negligence from the medical sides, the person can think of, okay, I will go to court or something like that. So
Yes,
we need
it's
to
possible.
check. Yeah,
It's possible.
Quite possible. It's
Yes. But the thing is, we shouldn't allow it happened once with us. So next time we take care that every patient is monitored so that there's no miscommunication between two departments. So
Do you think this will keep confidential to the patient? Agar this error happen to this particular
no, it's
patient?
not. It's not communicated to the patient. Not as a part of this thing, quality or safety incidents. This is a completely different system. It's only systems. It's not individuals. Neither the doctor or this one will be directly blamed. Yes. Thank you.
Thank you. Dr. Devika?
Good morning, everyone. So this is an interesting case I would like to put forth. In Hindi we say khoda pahad nikla chuha, the literal meaning being that you dig through an entire mountain and you found a very small mouse. So a 3-year-old female child presented to the emergency room with injury to the left eye while playing with the tip of a pen. And on bedside examination, there was a bluish black substance at the limbus, a small entry wound at the lower lid, and some bleed originating from the entry wounds. Apart from that, the right eye was completely normal, and then it was decided to take up the child for an examination for under anesthesia with primary repair of a scleral laceration, as the bluish black substance was presumed to be uveal tissue prolapsing from the scleral wound. A preoperative workup was done and a pre-anesthetic checkup was done. A skull x-ray showed a foreign body of about 8.5 by 2.3 millimeters in the left orbit, and intraoperatively there was a very small there was a bluish black substance that was there near the limbus. With a limited peritomy, we could expose the tip of the pen that was there. It was removed completely, and the underlying sclera was inspected. The sclera was completely normal. There was no breach of sclera. So just the conjunctiva was closed with 6-0 vicryl interrupted sutures. Also the tarsal aspect of the conjunctiva was closed from where the tip of the pen had entered in the subconjunctival space, and this is the suturing of the tarsal part of the entry wound of the conjunctiva, and the lid was also sutured in layers with 6-0 vicryl. So post-operatively, the patient was given topical antibiotics, steroids and lubricating eye drops, and at 3-week follow-up, patient was quite stable with good vision, healed conjunctiva and a quiet and formed anterior chamber. So what I would like to emphasize is that a case of subconjunctival foreign body, it is very necessary to rule out any open globe injuries, any intraocular foreign bodies, because most cases are associated with scleral tears and uveal tissue prolapse. Particularly in children, it is very necessary to do an EUA in even seemingly mild trauma, because we may miss any foreign body or any small tear, as the children are not very cooperative for a bedside or a slit lamp examination. And the patient was lucky to have not any other severe ocular injuries, and it was really, we were really glad that it was a very small or trivial injury. So we got this published as well. Thank you.
Thank you.
Thank you, sir.
Dr. Mustafa.
Good morning, one and all. I'll be presenting study of fellow eye in unilateral pseudophakic patients with good visual acuity presenting to a tertiary care hospital in central India. Starting with a little background, as we all know, cataract is the most common cause of preventable blindness and moderate to severe visual impairment. Worldwide, the numbers are estimated to about 90 million and India around 27 million. And among people 50 years or more, cataract is responsible for about 66% of blindness in India. I'm quoting the study by National Blindness Survey, Ranger sir and Surat Sangam sir. As we know, cataract untreated causes for around 66% and of blindness, and severe visual impairment around 48%. Presence of cataract, it not only reduces the visual acuity in the cataractous eye, but also affects the visual function of the fellow eye by means of binocular inhibition. Specifically, contrast sensitivity is affected. And after cataract extraction of the fellow eye, the normal binocular summation and stereopsis are restored. So early fellow eye surgery is recommended. The purpose of this study was to evaluate the fellow cataractous eye and identify the factors that cause a delay in fellow eye cataract surgery uptake in unilateral pseudophakic patients with good vision. It was a cross-sectional study, observational, done from July 23 to June 25. We included patients more than 18 years and unilateral pseudophakic patients with a vision of 6/18 or better in the operated eye and having age-related cataract in the other eye. One-eyed patients or patients with BCVA less than 618 in the operated eye, or having other comorbidities leading to diminution of vision, except age-related senile cataract, were excluded. We found out that these are the results. We found out that the mean age of the patients was around 62. However, the females in 70 to 79 age group were later, were a bit more in number than males. In my study, the total number of females were around 53% and males were around 47%. Education level of the patients. Most of the patients were educated up till secondary school or higher secondary school, with a proportion of females being illiterate or less educated were a bit more. Most of the patients that we encountered were either self-employed, females were homemakers, or had a service or self-declared job. Visual acuity in cataractous eye at presentation was less than 6/60 in up to 60% of the 62% of the patients. 12% of the patients presented with white mature cataract, and 4% presented with hypermature cataract, causing secondary glaucoma. The reasons for delay that we encountered were need not felt being the most common, specifically in males. However, the local reasons, citing seasonal preferences or no one to escort, was more in females. Only a few number of patients came to us upright with that a need is felt. This is the interval duration between both eye cataract surgery. We found out that the mean was roughly around 20 months. The median was 6 months. The peak was roughly bimodal. Majority of the patients got operated within 6 months to 1 year. And the other peak was the patient got operated after 1 to 5 years of duration. The discussion, unilateral pseudophakic patients with good vision are prone to delay in other eye cataract surgery. A sharp eye has to be kept on at-risk population, that is the females or the homemakers for maturing cataracts, and to avoid complications related to hypermaturity. The threshold for felt need is less. Some people come to us with other eye vision 6/9, some people come to us with hand movement vision. So the threshold for felt need is variable and is less for other eye cataract surgery. They can see with other eyes, so they come to us late. Health education and screening programs may be undertaken in community for early fellow eye cataract surgery. Thank you.
So your data showed that the patients were, majority were educated.
Yes, sir. We had a good number of patients were had done their secondary schooling, sir.
Yes. So despite that, there was a delay in the. So how do you correlate? I mean, education has no importance.
Yes, sir. Education does not. The felt need does not correlate well much with the education.
Okay.
It's quite variable. Patients had 6/9 vision in other eye. Still, they wanted to get operated, and they had 2 of the patients had phacomorphic glaucoma, and still with hand movement vision, and that was the only thing why they had come to us with 6/9 vision in other eye. So that is very variable, sir.
And of these patients, did you encounter patients who landed up with the phacomorphic glaucomas?
Yes, sir. We had 1 patient with phacomorphic glaucoma and 1 with phacolytic glaucoma, sir. 2 patients had complications, sir.
And they were counseled for?
They were counseled. Other eye cataract surgery was done. We had counseled that whenever in their family or in their surrounding for other eye early fellow eye cataract surgery as well, sir.
Okay, fine.
One very important point that you have highlighted, the reason why cataract surgery, the fellow eye cataract surgery is getting delayed, the need not filled.
Yes, sir.
Need not fell. So what do you think with this, the reason need not fell, it's so common in the context of eye, ophthalmic research, and when we see the various challenges. So what do you think, like, what should be the, we know that this is something behavior related. People don't believe, don't trust, okay, ye kaam chal jayega. So what do you think, I mean, how to solve this kind of the casual attitudes, need not fill? You will say every time need not fills, mujhe ko zaruri nahi hai. So what do you think, what should be the, that solution for this?
Sir, sequential cataract surgery is the norm. Immediate is we do not prefer a lot in India because of endophthalmitis risk. Delayed sequential cataract surgery is the norm. But how much delay from the first eye to the other eye cataract surgery varies in different populations. So when we encounter a patient where we know that she is at risk, she is a female, she is old age, she is uneducated, she might have other barriers. So at that very much time, we might offer her other eye cataract surgery at some reasonable interval. Catching when they reach at the first time. Once they've gone from the hospital after 1 eye cataract surgery, catching them then it would be a bit more difficult. Other thing would be, I feel, sir, screening programs for cataract in other eye, and because the need not felt, people requiring binocular very good vision are very not so much in number in the peripheral or the rural parts of India. One eye se dikh raha hai to dil ki kaam chal
So
raha
what
hai.
is the solution for that? You'll find so many patients, I don't need it, need not fills. So how do you tackle it? The
So
question is how
when
to
they
tackle
come to us for one eye cataract surgery, we counsel them for the other eye surgery as well. Or once they come, this is when they come to us. Or otherwise, we can go to them in the screening program, and then we can detect unilateral pseudophakia. The percentage is around 9%, and then we can catch them in.
My question is, whether science matter in this context? You know, the science, you have a science, so whether science matter or not, or something related to the cultural Indian context, social belief. So we need to think about the balance. So whenever, you know, the question, the answer comes, need not fail. So what I feel is science, I mean, should stay behind and think about the cultural aspects. So we think that, okay, one eye is still cataract is there, then you should come, they will not believe it. So in this context, my belief is science should behind and think about the local and cultural
Local
belief,
reasons,
traditional thing. Okay, that's
Yes.
my
Thank you, sir.
question. Okay.
Thank you. Next presenter, please, Dr. Indra Yudh.
Good morning, respected judges, seniors, and my colleagues. Today, I, Indrajit Bandyopadhyay, stand before you to present Vartalap, a novel counseling-based approach for quality eye care, and my co-author is Dr. Tanveer Ahmed, sir. The role of today's modern ophthalmologist is to guide the patient holistically towards a good health, both physical and mental. However, in today's fast-paced life, this is a Herculean task, as both the patients and the doctors are overwhelmed by the huge crowd in the hospital, and comes a time constraint, and as a result, what happens is the symptoms are treated but not the patient. Therefore, it is an initiative to provide a counseling-based, tailored, non-pharmacological approach to the lifestyle modification to promote the health of the patients, utilizing the time in which they wait for their turn in refraction room. My aim was to promote the quality of life by changing the knowledge, attitude, and practices of the patient with the objectives of ascertaining socio-demographic data, to understand the prevalent practices adopted, and to provide counseling regarding betterment of quality eye care via day-to-day activities. Now, my study population was all patients and attendants above 12 years of age attending ophthalmology OPD outside the refraction room. The study duration was of 6 months, and it was a prospective, observational, descriptive, questionnaire-based longitudinal study. All the patients and attendants attending ophthalmology outpatient department in the waiting area were included, and very sick or non-consenting subjects were excluded. It was done by a purposive sampling, and 719 subjects were included. There was no financial sponsorship or conflict in interest. Informed consent was taken from all adults, and assent was obtained from minors with consent from the parents. This is a questionnaire that we have used, which was a modification of the SF36 questionnaire, and personalized counseling was given in a Socratic manner. And coming to the results, we found the 719 patients, of which 660 opted for the counseling and rest 59 were treated as control group. Of this, 36.44% were females, and maximum age group was from above 60 years. These were the symptoms and divided as per the groups of those who opted for the counseling and those who did not. And as we can see, it has been tabulated, and scorings were done in the Likert scale. 40% reduction of foreign body sensation was observed in the group seeking the Vartalap program compared to the 22.8% in the control group. The incidences of headache, fatigue, and watering were reduced significantly in this group, which is 34.8% with respect to 28.7, 25% with respect to 18.75, and 43.9% instead of 39. As assessed, we found that quality of life improved by 21.7% in the group which opted in for the study, in contrast to the 13.3% in the control group. The dietary suggestions had the maximum adherence, which is 82.1%, followed by adherence to exercise, then screen time reduction, which came to 41.3%, and the least followed advice was regarding cessation of addiction, which was only 12.7%. Coming to the discussion section, similar studies were found in Department of Psychiatry, where with pharmacological therapy, non-pharmacological approaches were used, like in the studies of Corbisiero et al. And Kamenov et al. No similar studies were found in ophthalmological standpoint. These are my references. Thank you.
So, what was the content of this bottle of, you said the novel counseling-based approach for quality eye care services?
So, in this study, actually, what happens is if a patient requires refraction, mostly topical lubricant is given along with the prescription of spectacles. But with this, they often have residual complaints which they don't actually get addressed, and patients also have a huge time crunch, and neither the patients nor the doctor actually can handle this situation in the huge rush. So we have taken up the area waiting time in the refraction room, because like for refraction we usually have around 100 patients per day, and patients utilize this time for addressing their queries, like what else can they do other than the treatment approach.
No, my question is, you have the counseling, because we, in the practice, we usually do a counseling for cataract surgery, but yours is something like a novel, bottle of. So I want to know, like, consider that the counseling we are doing routinely, there is the traditional kind of counseling methods. That you are saying this is a bottle of, is a novel counseling-based approach. So what
Sir,
is the novel, what is the new thing here?
What is the content of this Vartalap?
So in this content, actually we ask for any additional problems that they are having in their day-to-day life, firstly. Then they might, like the most common thing that we have heard were headache and fatigue, which is often also not even addressed all the time by just refraction alone. Because headache also has multiple factors, like the day-to-day activities. Like, for example, a person who works in front of the computer 8 hours a day without any kind of break. Until and unless we reduce their screen time as such, refraction only has a limited role. But this is the thing which they many times hide just for getting the spectacles, and then they go away. Instead of this, we give them the spectacles as well as their medications. But as we probe much deeper, these issues come up where we give the counseling that they are to reduce their screen time, improve the quality of their diet, which is usually not addressed in a government hospital, like the aspect of diet as well as exercise, like the orthoptic exercise, which I mean.
So one more thing, is there any, like, suppose a patient comes to you, and is there any, like, okay, there's a dedicated counseling center, and there has to be someone who can decide about the behavior of that particular patient, someone is accompanying, something like, it's a new kind of thing, like, because in the practice, in OPD, we usually counsel, so is something like that, like, because one accompanying person who can decide, okay, something like that.
So, could you please repeat the question?
The question is that was there any counseling center? Who was giving the counseling?
No, sir. It was us only.
Doctors?
It was us, the PGTs.
Special counselor or counseling center, or doctors themselves?
So the doctors themselves. The program, we named it as Vartalap, and
so if you do counseling, then how will you manage your OPD?
Sir, actually, we did it by taking the day off. One of the PGTs are always on day off. Like the one who did the night before, we get the next morning off. So we actually utilized that morning session and came to the OPD just for this purpose.
Okay, thank you.
Okay, thank you.
Thanks.
बाकी उस सेशन में सबको सर्टिफिकेट दे रहे हैं, सबको जजेस को।
ऑप्शन था रिजेक्शन का? नहीं, वो एक मैसेज आया था कि उसमें यू कैन से नो टू वन सेशन. हाँ हाँ, वी कैन. The only we had a different concept in incident report. Teachers are routine. हाँ, लेकिन she बाकी अब individual को total out of given just the total. Because it will be difficult to. I think you can total we can bring. So that gives a clear cut idea.
Well, I think next session शुरू करना होगा. I just announce it. I was a convener, but same time I was judged.
Okay. Thank you all the many speakers for this wonderful session. So now we'll while Saurav is waiting for the next session. Take care, Saurav. Please go ahead.
Finished in time.
Yeah. Thank you. Just 2 minutes.
अभी मैं वहाँ भी कर लेता हूँ. ठीक है बेटा, अगर सर्टिफिकेट आएगा तो गिफ्ट देना.